Hey, good morning, everybody, and welcome to today's webinar. My name is Kathy Arsenault. I'm the practice consultant here at the Association of New Brunswick Licensed Practical Nurses, but I'm going to be just serving as moderator for today's discussion. So today's presentation, as you know, is about harm reduction, and it is my pleasure to introduce our guest speaker today, Brett MacDonald. So we're very excited to have Brett joining us today and giving us, he's a wealth of information on this topic for sure. So Brett was born and raised in rural New Brunswick, and he graduated from the practical nursing program at NBCC Woodstock in 2019. In only a few years, Brett has acquired a diverse background, having worked in long-term care, the emergency room at the Dr. Everett Harmless Hospital, and is now working in harm reduction for IV drug users at the Riverstone Recovery Center here in Fredericton, New Brunswick. Brett states that he enjoys big belly laughs, short walks to the pub, and country cooking. So we are very delighted to welcome Brett this morning and to learn more about harm reduction. Before I pass it over to Brett, we just have one quick poll question we wanted to give to everybody, just to get a little idea about what your knowledge base is in this regard. So I am going to launch a poll to you all. If you would just take a moment to answer, it's just a yes or no question. Any of the polls that we ask in this presentation, you won't see your name or anything, so you don't need to be shy. It's just going to come in as a percentage of how many said yes and how many said no. So you should see the first question on your screen now is just asking, do you know what IOAT stands for and what it means? So just a quick yes or no response, and then I'll share those results. I'll give you a few seconds to answer that. We almost have everybody. Just give you about 5 more seconds to respond, yes or no. All right, so you've got a lot of education to do here today. So I'll just share the results. So about 85% in attendance do not know what it stands for or means, and 15% do. So that kind of gives you an idea there. So I'll just take that down. Please, thank you, Brett. It's all yours.
All right, welcome everybody. So I guess for the first question, IOAT, that stands for injectable opiate agonist therapy. So I'm not sure if you ever see that on a chart somewhere, just for basic knowledge. We'll talk more about that in the presentation, but traditionally it would be OAT, so that would be opiate agonist therapy via Suboxone, methadone, which are traditional. But IOAT is something that we do a little different here at Riverstone Recovery, and is a big link and a big help with harm reduction. So those of you that don't know, don't worry. If you want a bit more explanation, I'll explain further on into the presentation. All right, as Kathy said, my name is Brett. I work in harm reduction. Basically, there's a couple of roles that I have here at Riverstone Recovery. It's harm reduction and is also considered community health nursing. So there's quite a bridge between our community involvement and the patients that we serve. So I'm just going to advance in. Oops. All right, so I'll just like to start with the land acknowledgement. I live, love, learn, and work in the traditional unceded territory of the Wolastoqey, Mi'kmaq, and Passamaquoddy peoples. It's important to recognize our First Nations people around us. The image that I chose that's there is actually the same artist that did the artwork in our first IOAT room. We're under construction right now as we're expanding, but I just want to do the correlation between Natalie Sapier. She's a very brilliant Indigenous advocate, and she also is very involved with what we do here for her own people, but also the walls that you see behind me are art by her. All right, harm reduction. So harm reduction is different in different capacities, and I'll talk a little bit more about kind of basic harm reduction and what we do here. But from AHS in 2020, that's who made this statement, and that's Alberta Health Services. Policies, programs, and practices aim primarily to reduce the adverse health, social, or economic consequences of those of legal and illegal psychoactive substances without necessarily reducing consumption. That's a big statement, and there's a lot of words in there, and it's so hard to sum up harm reduction in general, but this definition definitely coincides with what our aim here is today, and also with them. And we also correlate quite quickly or quite frequently with Calgary, Edmonton, and Vancouver with their IO programs. We are deeply connected with them. So some of the pieces of this presentation have their source. I sourced them from some of the Alberta group. So these are some examples of basic harm reduction. You see the top corner, PPE, as we all know, coming through COVID, especially in an ER setting, a long-term care setting that I'm familiar with. Those types of settings are very high risk for transmission, even in day-to-day. So PPE is considered a harm reduction. The ratio of patients to caregivers is quite outweighed. So obviously protection there reduces harm amongst your caregivers. First aid kits, obviously found in many locations. Vaccinations, needle drop-offs, those are very important. You see them in public bathrooms, you see them in gyms, you see them in any location that there might be needed. The bottom corner there, we have naloxone, which I'll go over later. The condoms are a great asset, and any other sexual inhibitors of harm. So even from condoms to PrEP, which is pre-exposed prophylactics for those who have sex with people with their HIV status is unknown. Speed limits, seatbelts, all of these are forms of harm reduction. So kind of gets your mind in gear that you're already doing probably a lot of these things today in your practice. But what I'm going to show you is a little bit more advanced with encompassing the whole spirit of what's going on with harm reduction across the board, even in basic examples. So approaches, there's different approaches to harm reduction. Obviously, there's recovery-oriented approaches and there's harm reduction approaches. For our case and purposes here at Riverstone, if you don't know what we do, I'll explain a little further. We're not detox. We are not a safe consumption site. Everything that we do here is prescribed. So from a harm reduction approach, interventions can be targeted at the individual, family, or community or society level. So kind of examples of that, the individual, maybe their needs are coming out of withdrawal, finding housing, getting on a different straight and narrow path. Family might be those who are affected by their condition or their issues that surround them, that kind of echoes out into the family dynamic. Community, that would be overall sustainability of their life, of their overall health, and to assist to contribute into society. Important component in recovery-oriented continuum of care. So you need to also assist after you've given all the education, you've given all of that you can. You need to continue this, and I'll talk a lot about continuing care as well. Person-centered, that's very important for us because not everybody has the same story. There might be similarities, there might be commonalities between issues, but everybody is an individual. They feel different, they have different aspects. So you'll probably see in any type of harm reduction center that is geared towards a highly vulnerable population, meeting people where they're at. That's very important. This will be echoed throughout your practice if you're involved in this type of care, or if you are in any kind of vulnerable situation or vulnerable involvement of a population. This is very important to consider. And the focus is on building relationships to improve access to care and support. So a lot of what we do is relationship building with the population that have failed a lot of treatment options, that have failed what's considered to be normal in society. So focusing on building relationships with people to improve access to care and support, that's very important. And there was a while ago, Kathy had put out a message for those that have come through COVID, and all of you out there have experienced many different things. And it's like, what good could have come out of COVID? And my response to that was absolutely nothing. With COVID, we were unable to meet people where they're at. So there was a lack and there was a slowdown in access into support and care. And sometimes the patients that we see, we might only have one window of time to obtain what they might need. So with barriers such as COVID, it didn't really help support this issue. Recovery-oriented approaches that recognize the importance, again, of family, friends, community, and the support and continuous. Numerous interventions, preventions, harm reduction, treatment and recovery and support. So a lot of that would encompass education and empowering people. Goals are defined by the individual and not by an organization or different plans. So this is where, again, focusing when you have the harm reduction approach of building relationship, it allows you to help facilitate or navigate some of those individual goals. And focusing on nurturing hope and stimulating recovery. That's very important as well, because it is very continuous, especially dealing with addictions and with vulnerable populations. To keep the recovery going is definitely a big part of what we do as well. All right, continuing forward. So this slide is a little different. This is one that I did source from out west. We actually do have an RN that works with us out west. We do, for scope practice here, we have LPNs that run the show, and there's some other RNs that do work with us, but within our capacity. So we do actually have an RN from out west who works with us casually, who worked with AHS in the IOT out there. So she's been a wealth of knowledge and assisting with different programs. So it's interesting that some of these presentations are kind of recycled around our organizations or our team meets or whatever, just because there's not a lot of information out there. It's just evidence-based practice built upon what we do day to day. So we're essentially building an airplane in the air. But for this this slide here, there's different types of programs out there, not specifically geared toward IO, but just in reduction harm reduction programs in general. So societal programs. So there's opiate dependent treatments. So there's OAT, which we already talked about, IOT. This would be the oral replacement. So this is opiate agonist therapy via Suboxone Methadone. The ODT, that's another acronym that you'll see out there, but we still consider Suboxone OAT here in New Brunswick. That's a dissolvable tablet. So that's an oral dissolvable tablet that's a sublingue, whereas some oral replacements would be considered like in a drink, like methadone, which is mixed at pharmacy, or it might be sustained release or long-acting morphine given in pudding. So you'll see opiate dependence treatments that are out there. There's alcohol programs, there's addiction consult teams, there's ARC teams, which is addiction, recovery, and community health programs. These are all associated, and these are things that you can find to assist people, especially with detox, with alcohol management programs. There's lots of information out there. But for those that are seeking it or searching it, may need your help as a caregiver to facilitate the avenue. Thus, that would be your involvement in harm reduction. Addictions and mental health. Harm reduction therapists, these are very hard to find. It's very hard to find clinical caregivers in psychiatric or psychology care in New Brunswick. So there are different avenues that we use. We actually had a DBT training facilitator that came, a psychologist that's dialectic behavioral training. So it kind of arms patients, you know, when they're feeling stressed of how to manage their own feelings. So there's a lot of unmanaged mental illness that we deal with. So we try to empower patients to recognize some of the signs and symptoms of what goes on with them to kind of manage themselves. So that'd be something to look up, would be dialectic behavioral training. There's lots of YouTube information out there. It would be good to direct somebody to some of these care options or self-care options that might be available where a psychiatrist or psychologist might not be available. Outreach and addiction counselors. We do an outreach program here, but with our counseling, it's usually done in-house with our patients. And then there's AMH treatments. Those are addictions and mental health programs that would be facilitated. I know Horizon has different programs available that you can, I think, self-refer or find somebody to refer to. Public health programs, sexually transmitted infectious services for partner notification programs. The Fredericton Downtown Community Health Clinic is a great advocate for community involvement and upstream thinking for harm reduction. They do have access for sexual health care over there. You don't need to see a physician. It's not an after hours clinic, but if you're seeking STI testing, education, they are more than geared to set up, and they have nursing standing orders there to assist with the same. Communicable disease control. A lot of what we do here at Riverstone Recovery, as well, is that we're monitoring different portions of STBBIs that might be affected by those who inject drugs or might be at risk. Health promotion and prevention. I am part of a Hep C team here as well. That's another one of the hats that I wear with my nurse manager. The two of us head up our HCV surveillance, monitoring, and treatment program. That's all nursing led, which is very exciting for LPNs. It's a huge opening to our scope. And community. There's peer advocacy groups out there. There's Aware, and there's one there, Mom Stop the Harm. This is a big organization, and you can probably find it on Facebook. There's different groups out there. There's websites for it. These are mothers who have come together to. There's different groups out there that'll do that. But if you look up what they do, it's very touching, and it's very warming, but also heartbreaking at the same time. Awareness campaigns, there's different posters, we have different educational pieces. I know in the ER by triage, there's a poster that is glued to the wall about what we do. So if a triage nurse is there and they have somebody who is an acute withdrawal that they might not be able to treat, we will take their referral ASAP and we can move rapidly to help assist that person. So campaigns really do help. There's another other campaigns that we do outreach to different facilities. This month we have a lot of presentations that we're gearing up to do to different areas. I know Woodstock, there's a public health learning day that we'll be doing with them about different campaigns that we do with harm reduction as being the forefront with that. Drug testing and drug alert systems. Now this is very important, more so for safe consumption sites. But we do provide, along with AIDS New Brunswick, drug testing strips. There is no, it's not a shock to any of you caregivers that there is a lot of cocaine, meth that is mixed and cut with fentanyl. But we do give strips to patients where they can test their drugs before using, if they're using outside of our programs. And again, we're not abstinence-based and we're not detox. So there is some side use and external use as well. So it's a lot of education that we give around how and when to use and how to use safely. This is a huge help. And if you're ever wondering, you can look online. I believe that somebody did say that you could purchase them through Amazon. I would be a little bit hesitant to that, but I would actually go to a harm reduction center that would have these strips to test or to advise your patients or those who might be seeking test strips. AIDS New Brunswick will be able to facilitate that as well. All right, moving forward. So basic principles of harm reduction. Now this is a general speaking terms of what we do. So pragmatism, and this is a big word, but what it means is why people do what they do without a judgmental why. So understanding, say, a patient of ours who might have extensive meth use, but only in the winter time. We'd understand why they would do that, because it numbs hunger and it takes away the cold. So if you're battling hunger and you're outside all winter without access to shelter and limited food intake, the reason why that they would do meth is just to mute that or to muddle those feelings. So it's not a judgment question to ask why you do the drugs. It's understanding the outcome or the reasoning behind or the rationale behind why that person does it. And that just breaks down to any other aspect of why somebody is needing help or is in that care capacity of harm reduction, of why they're doing what they're doing. So that comes into play by building your relationship, as we talked about, to understand when that patient trusts you, to ask them why or what's going on or how is this happening or what's happening to you. Human rights. This is a big one as well. We live in a socialist country. We live in Canada, so we all have rights to access competent healthcare. So this is a huge one. There's a lot of branches out from this, but human rights are a huge thing for us, because we do want to empower and make our patients feel as a part of society, which they are. Focus on risks and harms. Again, this comes back to the education piece. Like I said, we are not detox, we are harm reduction center. So we do not have we're not abstinence based. So we are a lot of what we do is education to patients on how and when to use. And surprisingly, a lot of them that have been, we have some patients who have been injecting for over 30 years, and some of the principles that we educate them on, some of them didn't know, for example, and I can explain this later. Hep C can be transmitted through the reuse of a wash. Some think that it's just from needle poking, but just that small intervention of unknown could save so many people from reinfecting or having new infections. Maximizing intervention options. That's something that we do here in our care capacity. We want to make sure, when somebody's coming to us for opiate replacement therapy, of what medication works best. So there's a lot of education for the caregiver on what we give for programs and what we're going to give or match their need with. And so the assessment points need to be on point. Priority of immediate goals, and right next to it is incrementalism. This is very important to understand the difference between these two systems here. So priority of immediate goals, if I have a patient in front of me who needs an oral replacement, and they have battled with the law and they have battled on the streets, but all they need maybe is social development so they can start a treatment program to get on insurance, and all that might require is a phone call. But for a patient who is living rough, that might be very difficult, and that might be the end goal. The first goal, the immediate goal, is to get health coverage so that they can pay for the replacement therapies. So that might be calling. Calling is very difficult. Some patients don't know phone numbers, patients don't have phones. So the prioritizing, or they might have an attention deficit, and they might not be able to wait online for over 30 minutes for social development to get through to make an appointment. So that goal of just getting social development can turn into an all-day thing. So prioritize goals and what's happening in front of them. Incrementalism is like, once you have your social development, as an example, and you have your replacement therapies, what happens next? Take small goals, one piece at a time. Involvement with people with lived experience. Now, this is very important. We involve our patients a lot, like almost 100% of the evidence-based practice of what we use, as the button there is beside it. So people with lived experience is very important to have alongside as a resource. And there's a saying that goes, nothing about us without us. That's very important, and that kind of drives the point home when you're talking with somebody, with and it's very exciting for us to hear what the patients have to say, and for our director or medical director to take that on board. And we do process changes on the fly a lot. So and also we include those who are affected by the individual around them. Of course, it would have to be a nurturing environment. So like the example of moms stopping the harm, this would be involvement with people with lived experience who may not have addiction issues, but might have those around them that do, and understanding and how to facilitate, navigate their health and overall wellness. In evidence-based practice, this type of care that we deliver at Riverstone Recovery and in different IOs across our nation, there's very little evidence-based practice. If you compare it to something like cardiac issues, respiratory issues, people have been studying those for years and years and know where to, to pull any type of information. Evidence-based practice is still building within this type of care. We're showing great improvements and positivity with it. So we're continuing to build this metaphorical airplane in the air as we go along. And social justice. So social justice is very interesting for what we do in harm reduction as well, because it's kind of like the ethics in ensuring quality or equality amongst our people. And here we have a whole team. We call it the Works. We have different teams at different hats, just because we're on a pilot. So like I said, we change hats very often throughout the day. We actually have a team called the Works. Now this team is designed for inclusiveness, understanding how patients would like to be included in society, and what people would like to know about their stories, or how much they would like to know about their stories. And just that basic understanding, and like I said, it's basically the ethics in ensuring equality. All right, I'll just kind of go forward. So harm reduction advocates in New Brunswick, this is very interesting. I will say Horizon at the bottom, I did mistakenly put that on there without Vitalite. I'm unsure of Vitality's involvement in harm reduction, but the ones on here I'm going to speak to in general. I put Horizon there because in my capacity in Horizon, when I worked ER, I had told my nurse manager that there were people that needed syringes, clean supply to go, and I knew that I had access to it, and if it was okay to do. There was some kind of not full understanding of the capacity, because it really hadn't been asked, and it really was unknown. So if you're going to do it, please get your nurse manager to oversee it if there's a policy for or against it, just to keep your seat covered. But for Horizon in here, I meant to put the UNB Associated Horizon logo because of the Fredericton Downtown Community Health Clinic. Across the way, their student programs actually have an outreach connection, and we outreach as well from Riverstone. So we meet Horizon on the street when we're doing outreach, and their students over there and our students, and how we facilitate, we group together to kind of divide and conquer. What can you do? What areas are you in? Who do you know who is on your care list? Is there priorities? Do they need blood work? Is there a follow-up appointment? Is there something you need to know? So with Horizon, I forgot to put the logo of UNB on there as well, and that was just to associate with across the street for us for the Fredericton Downtown Community Health Clinic. Recap is probably one you haven't heard of. It's a St. John based initiative, and this was a very, it's connected with us now. So we do have another Riverstone clinic that has just opened this past year in St. John, and it is actually connected with Recap. The two are in the same vicinity. And Recap is, as you can see there, it's a Center for Research, Education, Clinical Care for at-risk populations. Primarily what they do is a lot of Hep C eradication. Before we were here, they were doing a lot of different things with Dr. Webster and the Infectious Disease Clinic in St. John. And Avenue B underneath, as you see the logo there, they are kind of like an AIDS New Brunswick. They hand out clean supply, they give education, they have a peer support worker, they get involved as much as possible without the clinic, without clinicians. So this group, actually, I had the pleasure of meeting with both Recap and Avenue B. When I was a student, I did 2 preceptors, or a split preceptor between the ER at the DEC and with Clinic 1 in St. John with Dr. Webster. So with that, being educated in a lot of different infectious diseases, Hep C rose to the top, as well as HIV, but mostly Hep C patients due to injectable IV drug use. And with that correlation, it's always good to understand pragmatically where and why and how. So Avenue B actually has a lot of that information. So on clinical days, I did some community visits, and Avenue B was actually the place that opened up my interest in harm reduction. It was a place set up in the 70s, I believe, late 70s, by some nuns that were in the know of harm reduction way back then. And it was very controversial for them in their faith and their community, and for those around them looking at them as enablers. But in fact, their intervention has turned out to what Avenue B is now. And it's a wonderful program. And as a student, it was an eye-opening experience. So Avenue B is very much in the forefront of harm reduction in St. John, and very good advocates. And they would probably take any one of any students, anybody who'd volunteer to go and assist, make crack kits, give education, any type of involvement. If you're in the St. John area, those of you that are around that know Recap know that you're probably more than welcome to assist. They would probably love your assistance. Here in Fredericton, we have AIDS New Brunswick's office located in the industrial park. They connect with us a lot. They're one of our partners in harm reduction for Fredericton. So they actually, because we are on a budget as a pilot, federal money, so we forward all of our clean supply to the Medicine Shop King Street and AIDS New Brunswick, because they get grants for that, supply them as well. So our peer support teams will take their products or their gear, put it together in kits, and then we will redistribute from peer support at the pharmacy level downstairs. Ensemble is much like AIDS New Brunswick and Avenue B, but over in Moncton. Ensemble will be partnering with us in opening a new Riverstone recovery in Moncton as well. So we are in the midst of change and growth. So this pilot is actually kind of exploding around the province. And there's multiple others that I haven't mentioned. Any of those centers that would have clean supply, education, even when I worked in bar, I worked at a nightclub here in Fredericton, and what we would do is we'd have packages of condoms and just throw them out on the bar ledges anywhere, just throw them out anywhere. And you know, just those interventions, those are around, those are in everybody's capacity, just to assist with medical harm reduction. All right, so now I'm going to talk a little more about my role and about Riverstone and its involvement in its community placement here in Fredericton. So some of these slides, we haven't been able to get the recording or the updates of numbers just because stats take a little while for it to be impregnated into sharing. So in 2018-19, A's New Brunswick handed out a lot of syringes, as you can see there. And like I said, this does not account for the other centers that are handing them out that don't keep track of them. Avenue B does, A's New Brunswick does, which is what's allowed partly for us to be here, is that there is a need. In 2019, Health Canada approved the use of liquid hydromorphone and that's actually heroin to treat refractory IV drug use. And this is where we come in. So for us, what is Riverstone? So we are a caring community made up of a medical director, as Dr. Davison, our nurse manager, and licensed practical nurses, social work, mental health nurses, all working together at our peak scope, and then a little more. Along with outreach coordinators, peer support workers. Our approach is person-centered, as like said before in some of the in the previous slides. We are very person-centered, trauma-informed, non-stigmatizing, harm reductionist, and evidence-based practice as we use. We believe everyone has the right to healthcare, housing, dignity, and purpose. So this goes back to part of the social justice thing where ethics ensuring equality comes into play. And how we came to be, if anybody is interested, I know that we've all taken healthcare in Canada and how some of these links work. So Healthcare Canada announces 76.2 million to address Canada's toxic drug crisis. So in September 2019, Dr. Davison had proposed the Multidisciplinary Treatment Center in Fredericton. In February 2020, Riverstone is picked as one of the 5 national multi-year projects funded by SUAP, Substance Use and Addictions Program, in February of 2020. This was really big because of all of Canada, from coast to coast, north to south. There's a needs assessment made in each province in different cities, and they only had enough money to open 5 across our nation. Fredericton fits the needs assessment for one of those, and thus here we are. So July 2020, participant intake started. I actually started here casual while still working in the ER. And a lot of this, I started in the beginning. So I remember how we've evolved. Even our own evidence-based practice has pivoted and changed many times. So we started doing intakes and starting people on oral replacements and as well as stimulant replacement programs even before the injectable was here. So in October 2020, we finally got everything together, got all our ducks in a row, and we started our first IOT injectable opiate agonist therapy recovery center here in New Brunswick. And I'm actually sitting in the room, like I said before. A lot of people were excited and on board with this assistance, including our artist, who was, you can still see the art behind me. Everybody wanted to be involved that could be, and still to this day, there's lots of people who try to seek us for involvement, which is great. This slide I just put in here just so that's the only thing that you focus on. We are not a safe injection site. The differences, or safe consumption, safe injection, supervised consumption, all of those words. The difference is with IOT is that it's all prescribed and managed by physician and drawn up and double checked by nursing professionals. So safe injection site, this is where a whole different type of care would be involved in pre-assessment, but there is still one that is needed because we still have IV drug use in the city that have no intentions of practicing safely or using with us, that primarily want to be on their own and left alone. So this probably would lead them into having care or start building that relationship and possibly transitioning them out from their unsafe supply to our safe supply. So that's why we say there is one needed for sure. If we could somehow reach that demographic, we would be in easy change after we build that trust and rapport to change over to what to prescribe to make it even more safe and less harming. So again, it's just kind of like revisiting why people take substances. And it's very heavy. It's a very heavy topic because it's something that, like I said, affects a lot of different people. I mean, you have groups like Mom Start to Stop the Harm, different family dynamics, a whole lot of different things. But it's not just the fact of just quitting drugs or what have you. I mean, you have social connection. There's a lot of different people that come together over drugs. There's loneliness, depression, trauma, an ill prescribed treatment that might have got out of hand, that a dependency might have been created from, self-medicated. Maybe you don't have a physician and you're purchasing somebody else's benzos. There's that as well. Coping mechanism. A lot of trauma is built in vulnerable populations, or had to have been experienced in vulnerable populations. Self-discovery. These are those who experiment with drugs and maybe they go wrong and they develop dependency or have addiction issues within that they didn't know. Peer pressure. This happens all across the board and at any age. Availability, there's lots of different availabilities. It's kind of scary now. Some drugs can be purchased on Amazon as fronts for like different small item knickknacks, but in behind the scenes, what they're actually getting in packaged form would be fentanyl patches from China. So availability, we're noticing, is becoming larger and increasing. And pleasure. That's again kind of to do with like the loneliness, have your drugs to kind of pull you out of that, and pain. We do have some different patients that have come to us from what we call medical misadventures, that might have been prescribed substances that they gained no relief from, but prescriptions have been cut and purchasing illegally off street or somebody else's through diversion. So different avenues of why people take substance. So this is the pragmatism version of it, not the judgmental version. And so recovery, this is often the case with caregivers, is the expectation is linear. For vulnerable populations who have unmanaged mental illness, who have no control over their impulses with drugs, the reality is the scribbles underneath. So somewhere in those scribbles comes interventions or community placements or clinics like Riverstone Recovery, or different harm reduction aspects or approaches, even through our associated advocates around the city and around the province as well. So as you can see, the expectation as a linear line, in reality, like this slide is very important to us, and this is one Dr. Davison uses quite often in presentations. It was said to me a couple of times, and it's echoed, and it's kind of upsetting. I had an experience in the ER where I had a patient who was in withdrawal with no acute distresses, no stroke, no heart attack, no open wounds, no evisceration. They were battling heavily their drug addictions, and I noticed in the ER, when you have a patient, you go through their med list. This patient was on methadone. And I asked, having my experience here, if you're on methadone, how come, this isn't working for you, in an educated asking why. And methadone wasn't right for him, but knew of no other options around. And with the physician in the room stating, if you just stop drugs, all your problems will go away. That's that linear expectation. Not undermining the physician in that moment, I did give the patient the opportunity to say that there are other options in the city, and that was my advocacy. That patient took my advocacy and came to us and has been on a great path with us, has even relocated out from our recovery. Like I said, we meet them where they're at. This was a great story, but understanding, I just want to drive the point home, the expectations of recovery are not linear. All right, moving forward. Trauma-informed care, like I said, not what is wrong with you, but what happened to you. And I think if you notice, I remember in my licensing exam, which wasn't that long ago, a lot of the questions were open-ended questions to understand more about your patient needs or what's going on in a non-judgmental fashion. You're not going to know anything about that patient without asking, details, because this can actually help their care. Again, that nothing about us without us statement. So medical treatments. So opiate use disorder, or OAT, opiate agonist therapy, includes buprenorphine and naloxone, which makes the medication Suboxone. That's the ODT, so dissolvable tablets. Methadone and sustained released morphine or morphine sulfate. So these are traditional. They work well, but they don't work the same for everybody. Some patients absolutely are disgusted by Suboxone. Some patients can't even handle methadone. So that's why we have to be creative in our approach to see what works for them. For IOT is the injectable opiate agonist therapy. This provides liquid hydromorphone that participants can self IV inject or sub-Q 3 times a day, plus a long-acting medication for overnight. So just to kind of explain that situation, as you know, or some of you may know, methadone is a once-a-day treatment. It can be adjusted with the physician. Suboxone is the same. Both work differently in your pharmacology. One takes less medication than the other. So Suboxone, we usually start at 8 milligrams, whereas methadone, we usually start at 30. And it all depends on what the goals are, your assessment, their goals, their immediate goals, and their incremental goals of what they would like. The injectable portion is a little bit more extreme, and it's for those patients that are very acute in their withdrawal symptoms. So those other substances are once a day. The sustained release morphine as well, Cadian. That's actually morphine sulfate. We also use another medication, Meslon. Those are once a day treatments that last for 24 hours. If it's for pain, those would be the ones that we typically use. Instead of different increments throughout the day. But IOT is very short-lived, it's very acute. They can come and they can eject up to 3 times a day within 3 hours apart. But when we're not open overnight, we want to make sure that their withdrawal needs are met and that they're not into withdrawal. So we give them a sustained release medication to last them overnight from our hours of close until open the next day. This reduces them for their cravings or their use on street, and hopefully that they curve all of their use to us. Stimulant use disorder, or SRT, this is something unique that we've been able to add to our offerings to our patients. This is not common in typical methadone clinics. Stimulant agonist therapy such as dextrogen and Concerta, Abilify. These are medications all contraindicated. Some of you out there who work in psych care would probably understand that these are psychotic medications, antipsychotic medications, sorry. But these actually, they curve the use. For example, meth use, cocaine use, we all know that those are stimulants. They can be injected, snorted, eaten. These are highly addictive substances, but we need to understand the pragmatism of why they're using them. Is it because they need that big rush? Is it because they have unmanaged ADHD or hyperactive disorders? Are they experimenting with stuff that they got hooked to and didn't mean to? Or is it because they're lonely? Again, it goes back to that fan slide as to why. So this is a little bit different for us. It requires a different type of assessment, and it may involve the doctor. But as far as our skill set goes, as LPNs, you have the education behind you, and we do have the qualifications here to walk a patient through which stimulant replacement would be best for them, along with standing orders, and we can rapidly start people ASAP without a physician. So the two things here that I kind of want to drive home, and just for pharmacology, just because you're probably wondering how this portion might work just a little bit. Meth and coke, as we know, are stimulants. They're either doing it to get that blast, but what happens with Dex is also a stimulant as well. So when taken daily and incremented up to a certain amount, the stimulant is actually slow burning in the background, which depletes the human's want to go have a blast of cocaine or smoke meth or however they administer the use. So this kind of dulls the need in the background because it's constantly burning. It has no effect on their cognition in the daytime. It doesn't snow them. It doesn't make them more hyperactive or anything. It's just a once daily built up in their system over time. And we will see the curve. Now we know dextrogen isn't a sustained, or it's not sustainable to be on for longer than probably 90 days with us. That's what our trial. And along the way, we have case managers, psych, and everything kind of check in to make sure that the curve of use is there. And then if it is successful, we actually flip them to Concerta, which is a more sustainable medication to be on than Dex for life. Now for Abilify or amitriptyls, or I can't even pronounce it this morning, but Abilify. This is actually to combat the warm hug. So if they're not using it to get a blast to get that rush, and maybe they're lonely, they feel down or sad, this is actually a dopamine block. So this medication actually kind of gives the warm hug in the background that they might have been needing from the drug. So this is very interesting, and I would be open to any questions or even know-how if anybody else has any information on anybody who has used any of these drugs to combat or to assist with the curve of stimulant use. And we also have rapid we have rapid treatment for Hep C. Like I said, I'm on a Hep C eradication team here with Riverstone. So we have identified and worked up more than 50 people with untreated Hep C, including more than 10 public health, including more than 10 public health we're aware of. So this number changes. Like I said, these numbers are different because we're constantly growing every day. We have new patients and intakes and different things, but it just wants to understand here, for us on our outreach, we can reach different people in different areas that might not be coming into general society or general population for care. So therefore it would be going unknown and missed. So we're actually, public health connects with us quite a bit, just to verify who we have and who they don't have in case somebody got missed somewhere. Just to keep everybody updated. So it's not that public health isn't doing their job or anything like that. We give all of them their information just so that we can all be aware of the same people and who's providing treatment and who is getting treatment. And a little more on IOT. So IOT is, again, like I said, it's an evidence-based practice, high-intensity, cost-effective treatment for those who have not benefited from other treatment. So again, opiate use disorder, and there could have been a patient on methadone for years and years and years, and it never really worked for them. They could never see the doctor. They could never make an appointment, could never keep the appointment. There's all kinds of barriers that are in the way. And they use on the side, but maybe all they wanted to do was use on the side and not methadone. So this is where this comes into play as another option. It benefits not only the individual for reduction in deaths, but also in the community. So it lessens their carrying of illegal substances. And it also, their needles and sharps are used in facility and they do not take them out. So we limit use syringes on street as well. The primary aim of IOT for us is to improve the health of the individual by reducing overdose risk in other treatments and health and social harms associated with ongoing injection drug use. The second aim is to encourage individuals in addiction treatment who have not benefited from less intensive treatments, who have been otherwise unable to access other forms of treatment. So that again goes into play. There are other physicians in the city who provide however, the unique design that we have here, because it's LPN led and with standing orders, we can rapidly move somebody to treatment within a day versus making an appointment that might be 4 to 6 weeks out. There's a lot that can happen in that time frame. And then once you're up and running in consistency, some of these other clinics require a meet with the physician. And again, that might require every 6 weeks. And if you miss it, then it goes on to 12 weeks without having a dose adjustment. Therefore, you may lose the patient. They may use more on the side, more than they intended to, because they're not meeting their needs. This treatment that we provide here, we can do rapid changes, quick pivots within a day. We can start people on treatments within hours versus waiting weeks and possibly months for a treatment plan. So in the picture, you can see the background. There's Dr. Davis in there, and that's one of our patients, Thomas. He, of course, he's a very strong advocate of what we do. He is part of our peer support. We called him, of course, we're nursing, and we always like acronyms and puns. We call him our air supply. So he's our artist in residence. So he makes sure that there's he facilitates an art group. He actually has a degree in education in fine art. So we use a lot of talents that we have in-house. So he helps facilitate part of the inclusiveness with our works team to facilitate different art groups for people for something to do in the day. He's been a really good advocate for what we do. And again, there's Dr. Davis in there. And the booths, as you can see, are set up. There's a mirror in place, so that allows for nursing to see what's going on the table in front of them. When they come in, they drop all of their items, and there's doors, little cupboards, so they have to put all their items away so we don't have to risk diversion or them leaving with syringes. And they inject in each booth. there and drop their sharps and then leave. So we've actually just rechanged that. This is the room that I'm sitting in, as you can see in the corner. This whole room is just a mess right now. We have taken over the space that is the same size of us behind us in our building. So we are going to advance here as well. All right, moving forward. Consistency in approaches. So this is very important. Any of those who work in psych care understand consistency in managing people's wellness is very important, but also consistency in addictions with unmanaged mental illnesses. This is very important. So we have very firm boundaries as set by Dr. Davison of what is allowed and what isn't allowed. And the consistency doesn't change. Our rules have always been the same. We start at 8 in the morning and we're done at 6 at night. But in our windows of tolerance for people coming in 5 minutes early, even though it's almost at the 3-hour mark, it is not accepted. It has to be right on the hour every point. And they understand this. And as we go forward, it starts that the culture remains. So we do that in different aspects. So consistency is very important. So screening, this is kind of like the continuum of care. We have patients stop and restart with us all the time. And this timeline, again, this is an image taken from out west and how they perceive their care and the continuum of care. We adopt the same thing here, and it's becoming part of the evidence base for this type of care. So screening, obviously we want to have the right people with the right medications, and we don't want to start somebody on something that they shouldn't be. So, I mean, we do have, parameters set in place that, we don't want to start somebody and create an opiate issue for when it's not there. So we have to have all of our screening, our assessments done, our belief in the intervention. So whatever one you're putting forward, make sure that it is the correct one for that patient. Rapid access to clinics. So this is where our case management comes into play, and our psych nurse that advocate or facilitate liaison between other providers for different things. I mean, we have patients that come in and we strongly advocate for their health. Even though we are a specialty area, we are not ideally primary care, but we will do episodic care. Say we find blood pressures that are 200 over, 100, 110. That's something that should be reported, obviously. So we report to Dr. Davison. We may start that patient on a cardiac med, but it only might be for 3 months episodically until we can find a caregiver who can continue their care, as we are not labeled as primary care, but Dr. Davison will do episodic care for patients in between and rapidly. Community outreach, we want to make sure those that are with our patients, even on the outside. So we have injectable patients who come 3 times a day, get their Hep C treatments, all of the things that they do correctly, practice safely, but also we do have a large population in the city that do not seek care for their IV drug use, and our patients interact with them. So it's good to have an outreach out there to allow these people safety. If our patients have just been treated for Hep C, they go interact with another community member of their own and they reuse a wash, or they have, equipment that they reuse and somebody else is reinfected, our patient's reinfected, that's not very good. So our community outreach goes out beyond even our patients. So if somebody's seeking Hep C care, we will take them on and treat them even if they do not want any replacement therapies. So an outreach is very important. I do outreach as well, and some of the other nurses here. We have a peer support person who knows every tent site, who the people are who might need care. I take a backpack with me with dressing supplies, intake sheets. I take dry blood spot cards with me, and I'll explain what that is in a minute. I'll take pregnancy tests, I'll take urine cups, I'll take rapid dips for urines, and I can have people started at pharmacy levels and when I get back to clinic and get everything going. So outreach is very important, especially in the community, from different avenues, from your patients and from nursing teams as well. Withdrawal management, this is very important as well. We want to manage people's withdrawal. It's a slow increment to get up to their desired dose in IOT, so they have to work with us. So even when we do Suboxone inductions, we want to manage their withdrawal symptoms too. So if we're taking them from one medication to another, Dr. Davison at the goodness of her heart has put together this prescription called the withdrawal kit. So if we're doing a Suboxone induction and say they have bone joint aches or upset tummy or perfusive diaphoresis, we have medical management to assist with the letdown of their withdrawal while they're changing medications. And that would go again with pharmacology or pharmaceutical interventions for their dosing, making sure that we have them at the right doses, that nursing is competent in delivering some of these chemicals, even if they're the same chemicals, at different doses could possibly harm, kill somebody. We want to make sure that those interventions are well looked after, pharmacy level. We always are all double checking each other's work, and sustaining wellness and ongoing care. So even if we have a patient who has come off all of our medications, and we like I said before, we are not detox, but we can detox and we can bring people out and off of all of their substance if needed, if that's the goal. So even if they have come off all of their treatments and successfully and they're ongoing into general population, we do not discontinue their care. Several patients have come back and participated in groups to advocate for how they've done it on their own with assistance, or with us with assistance, or however it is done. So we try to involve as many people as we can for those who've lived with experience. Again, nothing about us without us statement. So we want to make sure that that is ongoing. Also inclusiveness. Our works team will work together with some of these patients to rebuild resumes, practice interviewing, different types of care and ongoing care to subject them back into general population and make them feel like they're a part of their community. Naloxone. Kathy, do you have a poll question?
I do. So we have two poll questions we're going to launch to you right now. If you wouldn't mind participating, I'll just bring them up on the screen. So here comes the first one. So injectable naloxone can only be administered by a nursing professional with a physician order, whereas naloxone nasal spray is for the general population to administer. So it's just true or false. And again, it will just come up as a percentage. So you don't have to be afraid of being wrong. Your name won't come flashing on the screen or anything. It's a tight race right now.
I see that.
I'll give you about 5 more seconds. If you could just take a moment to participate, true or false. Okay, so I'll share those results with everybody. So 53% believe this to be false and 47% believe it is true. So if you want to give us the correct answer, and then I can launch the second poll.
Sure. There is no need for a doctor's order, and anybody can administer injectable naloxone and nasal spray.
Perfect. And so the second question for you all to answer. There you go. So again, true or false, naloxone can assist with a stimulant substance overdose. Okay, 5 more seconds. Perfect. So I'll share those results. So 83% believe that to be true and 17% say false.
Naloxone is an opiate. It's only for opiate overuse. Sorry, opiate overuse. So the thing is that it's going to it's not going to do anything for somebody who is going to have a stimulant overdose. It's just to reverse the effects of opiate use. So that's a huge thing to do in your assessment of when and how to give naloxone. So I'll go over that with you in just 1 second. All right, so naloxone, how and when. I'll give the self-education thing here. I put towards the heart in there. Towards the Heart is a great campaign, and they are out of British Columbia. And the thing is that they do a lot of harm reduction, um, advocacy, education, and as you can imagine, and you've probably seen in news and through social media, there's so much going on in Vancouver with vulnerable populations and at-risk populations. Toward the Heart is used quite a bit with different advocacy groups, especially AIDS New Brunswick, and here as well. If I have students with me, usually if it's a slow time in the day, I will make them sit down and do the self-education on towardstheheart.com. So if you go to that website, across the top of the band, you'll see educational parts of it. There's an online training piece that you can go through, and it's kind of like every other test that you've gone through. I mean, you can skip to the end and do the test if you want, but it's very good knowledge and very good educational piece to go through. They go through details, why, when, and how. And they'll also give you a certificate at the end. I'm not sure if they still do this, but you can try it out or call, and it's no problem to do. When you complete this course and you have your certificate, you can actually take the certificate to AIDS New Brunswick, and they will give you a naloxone kit for yourself to take in case you might need to administer it to somebody. Now, I'll quickly just state why it's important to do injectable naloxone as opposed to nasal spray. Nasal spray is not going to be effective if your patient is not breathing, obviously, because there's no inhalation and the medication is not going to get to them. So it's different. I just want to put it out there. It's your choice. You can buy them at pharmacy as well. I was a little shocked. I was at Shoppers Drug Mart one day, and I seen they had naloxone advertised in the window, and I asked to pick one up, and then they're going to charge me, I don't know, it was $60 for the kit. And that's a barrier. As advocates for health that could possibly rescue somebody, or somebody who might need it, who might be injecting with a group of people in a trap house or in tent cities or in shelters or wherever, they don't have $60. If they have $60, it's either going to go towards something else. It's definitely not going to go towards naloxone. So we need to strive for better to get more naloxone in hands of people who might require it or who might need it. But actually, it's kind of interesting. We had a whole bunch dropped off to us in the kits that you see, the black container kits there, that have actually retractable needles in them. So once the naloxone is given, those needles, the syringe will hold the needle. It'll go back up in, so it's safe. So you don't have to worry about it on street. Here in clinic, we have naloxone in every room, but we make our own kits from pharmacy downstairs. So we have naloxone everywhere, and it's checked. It should be checked off every day if you're in this care capacity to see when it expires. It's very important. But the use of the nasal spray is not commonly used amongst this population, just because with the snorting of different substances, septums that are blocked, patient could go unresponsive quite a bit, especially if they've had a big hit of morphine in the parking lot or something. We've had to respond to some soft overdoses, but always injectable. And it's also a peace of mind for the caregiver or the one providing the naloxone, is that you know that the patient has had it. Typically, it comes in an ampule, a glass ampule that you'll have to break and draw up. It's at 0.4. So if you want to think of it this way, each vial is about 20 minutes. Don't entirely quote me on that, because you would be subjective of the patient, of what they would have had for intake, what the type was, if it was a hot shot of morphine sulfate, meaning that they could have broken down the beads from their pill, put them in a syringe and shot it. Or it could be cooked down fentanyl patches drawn up in a syringe and shot, but you don't know the intensity of what's going on. But generally speaking, we kind of like the idea of each vial would be about 20 minutes of safety. So when giving it, we often run into different issues with EMS. EMS has syringes that are at 0.8. Keeping in mind that these patients that have injected, or that they're used to this culture. And it's kind of scary if you're the first responder, or if, as a caregiver, or as somebody on street who takes this training, you might just want to keep giving the rounds until they, out of anxiety or out of the excitement of whatever is going on, you might want to, your you might want to just over give. But what happens if you overdo it with naloxone is you put the patient in precipitated withdrawal, which can result in probably the worst hangover that they've ever had. And it's induced by you. So that's where it comes into also understanding the rapport and the safety mechanisms you've built around your patient's trust with you. When they see EMS coming, like once you give your 0.4 and you know there's breathing again, they're responsive, you wait until their own faculties come into play before giving another round. Those that keep giving rounds of it, you're just going to make the patient very uncomfortable. So it'd be very important to understand the signs and symptoms, and even when they're rallying and coming back out of it, just to understand when and to get them to an acute care setting, because it could be prolonged. Even if you do give 0.4, the medication or the substance that they have on board might still come back because it hasn't fully dissolved. So it might be just a short time, like I said, 20 minutes. I'm not saying give it in every 20 minutes, but definitely look at the signs of recovery or their ability to rouse. So we want LOC ×4, that's person, place, time, and situation. Even if they're still groggy and dopey, as long as they know where they are, they know that you are there for their safety. However, it can go the other way too, where you have no idea how much substance is on board. And so it's okay to call a code blue, especially if you're in a care setting or even in public setting, as there's AED, those types of things. So just review, you might be the only person who might be educated on how to do CPR and naloxone, and this could be a possible thing that could happen. And I'm just using an example, King's Place, there's a lot of people who use the bus system. A lot of people, used to use in the bathrooms there and just out and around. So different hotspots around, even in this city, where you might have somebody that could potentially be in an overdose. So it's just good to have education around what's going on. We educate our patients quite a bit. We put together kits for them as well if they're requiring extra, and if we don't have it, just because sometimes it's short supply, we will use our own supply and educate them on how to use it safely and amongst themselves. And yeah, any education with that, please go towards the heart, do the self-learning, collect your certificate, and either purchase one or try to locate one for free and have it on your person. You may never know when you may need to use it. All right, moving forward. Trying to anyway. All right, so adjacent treatments or adjunction treatments of what we provide here. So we advocate for housing, especially for people with concurrent disorders. So part of our care teams here, we have a social worker and we have a psych nurse and we have an LPN who doubles as a case management and with us in clinical delivery. So in the case management team, they work together with the by names list. They advocate for different housing projects. We have some different shelters around the city. They try to advocate and try to locate beds for some of these people, although it is challenging. Some of the rules that the shelters have been a barrier that we have seen for some of our patients. We have peer workers on site here. We try to, once we have somebody balanced and kind of leveled out in their treatments, for example, we might have a patient that might be injecting with us for life. So the recovery bit might be different for them. They might have gone off street. They might have found housing. They might have found a job. They might have other sustainability, but that might have taken a long period of time. And all the while they have been injecting. They've been injecting safely. They've been able to use that money for other things, either for nutrition or being able to pay for a room somewhere that's subsidized or whatever. But this is where it comes in and its difficulty sometimes for caregivers is that they might not never be off the pin or off the needle, but they have recovered in so many other attributes where they don't have to worry about where their drug's at. They don't have to worry about their withdrawal. They don't have to worry about being judged because we provide all of that care. So if that's the lens sometimes that the nurse sees all the time, other than what goes on outside of our walls, it can be kind of like a little bit like, is there something better they could do? Could we decrease their dose? Are they ever going to come off these meds? they might need that to sustain for that episode in time while they're getting other things together. So that's something that we need to realize that we need to work with, and our peer supports really do a good job with that. Our framework is that we do have piecework. We do employ some of our patients. They have to apply for it. We have cleaners. We have other facilitators for other teams and groups. So we make them go through the steps that anybody would in general population. So they need to sit down and make a resume. If they have difficulties reading or writing, a caseworker will put them with somebody who can assist. We do have some people who cannot read or write. So we have groups that can outreach to sources that can assist with them. So a lot of development there. Psychosocial supports, building on healthy coping strategies for life skills. Again, I told you we had a dialectic behavioral training facilitator that came in, and it's basically arming our patients to deal with some of their own mental illness or blocks while out in society. Now, traditionally, you'd need a diagnosis, you would need a follow-up, a medication probably, or some kind of ongoing care. Sometimes we need to equip our patients with whatever we can when we have them, and then let them go because we may only have them for a window of time. So building those supports and building those trusts so they come back to get more to go forward, that's also another attribute of care that we provide. So Kathy, do you have a poll question?
I do. So your last poll today, I'll just bring that up for you. So it's a true or false again. So a patient will test positive for HCV antibody for life after having treatment. True or false? Okay, I'll just give you a few more seconds. We almost have everybody. Okay, so this one's pretty tight as well. So 58% say it's true and 42% say false.
So it's true. An antibody, Hep C antibody will follow a patient for life, even if they do not have an active infection, or even if there's RNA not detected in the blood or no target found, the antibody will stay there for life. All right. So again, a lot of what we do here is like continuous and wraparound care. HCV prevalence is a huge one that we deal with for STBBI testing. Of course, we do test for a lot of different things in our intake. So when a patient comes to us for intake, part of it is Hep C screening, HIV screening, syphilis, any STBBI. We do STI. As far as our urines go, we do chlamydia, gonorrhea, we can do pregnancy testing. We do all of this stuff right at the get-go. This allows for a fast, rapid treatment for Hep C. In years previous, if you had a Hep C infection, you had to wait until your symptoms were almost killing you before the government of Canada would provide treatment for you. Now, Canada wants to eliminate Hep C by 2030. Keeping in mind, they're not going to do that unless programs like ours exist, because we have found so many Hep C patients that were going unnoticed. For example, a couple of slides back there was over 10 in that slide at that period of time that public health didn't know about. So if stats are being reported to public health and based on what they find and they think that's the actual number, it's not true. There is so much Hep C that is not uncovered yet that we are only kind of scratching the top with. So in spring 2022, it was determined that 80% of IO participants had a positive antibody and 50 had an actual viral load. So over there to the side is an estimated 25 or 250,000 people Canada are living with HCV, and over 110,000 of them are unaware of their diagnosis, or unaware and undiagnosed. So that, again, this is a big risk. If we have people coming and injecting, and this is their habit, this is their culture, and when they leave, some of their friends who might not be part of our program could have active infections. They could be partying, they could be not with their full faculties, and they could be doing unsafe practices at home, reinfecting our patients. not a good thing. The treatments are very expensive. It's between, I think, $30,000 and $50,000 per treatment per patient. And it's been unknown how many times they can be retreated. That hasn't been precedented yet, just because this population has not been fully exposed to this type of care. But in the past, it has been to general population where it's been no problem, where you've learned your lesson, you felt, you in any capacity of how you would have acquired it. But that works in a general population strategy. For us here, we've actually limited 7 clinical visits to get Hep C treatment down to 2 visits with me or with Michelle, my nurse manager. We can facilitate inception to completion of their treatment. That's nursing led. Big change and big for us as LPNs here to do that. But it takes a lot of education, know-how, build up, and with all the parameters in place. Typically, this would be an infectious disease doctor specialty, but because it coincides with what we do here, we want to limit the complicated cases. We want to limit cases to the infectious disease doctor that are not complicated, that nursing could handle on our own. So in the blood work that we get everybody right off the go, because again, we may never see them again. So if somebody comes in and they do an intake and they realize, that this isn't the program for me, and they disappear, or they never go pick up a pharmacy, if it's an oral replacement or if it's stimulant replacement. But on that point of intake, and we have obtained blood, we would be able to screen them for Hep C, and then maybe pull them back and treat them for Hep C if they don't want anything else. So on intake, that would count as the first visit. And then the next visit would be 6 months after for some serology and then a physical exam. And then if everything checks out as uncomplicated, we go ahead with the treatment and we deliver it with their daily dispensed dosing at their preferred pharmacy. There's a lot to that I just said, and I know there's probably going to be several questions going forward, but just for teaching purposes, Katie, I'm not sure if any of you out there have used that group before. We partner with them quite a bit, and they were actually quite excited to work with us about our HCV pathway, or our Hep C care pathway. We've educated them on how we do it. They have all the education, and if you ever want to go to learn more about harm reduction, they have a whole page on harm reduction, articles associated and groups associated across Canada. Anything you need to know about HIV, Hep C, or any STBBIs, they are a great community advocate for our country. I say community because as a whole, when you think of some of these illnesses, some of these groups that we're talking about, the groups are small, and we try to use as many resources we can across the country, so community as a country. I would invite all of you guys to check out Katie. They give out lots of information if you're in a doctor's office or if you're in any community care capacity. If you go online, you can order all kinds of swag from them. They have all kinds of interesting things. We get their posters, their pamphlets, or brochures. They hand them out for free. So any type of education that they can provide is really good. And I think they have webinars as well and educational pieces. But if you're looking for some of the education on how it works, the virology, what interventions are needed, places to go to test, you can advocate for your patients if they need any of this information to go there, or to contact us if they need. So overall, we're kind of advancing in how to process care. So how to access us. You can walk in 7 days a week. We try our best to rapid access patients. So with Dr. Davison coming from well, both of us have conversations about and living in Toronto, where they've always had hassle-free clinics. You've probably heard of them before. That's kind of the idea. We want to bring somebody in, treat them as quickly as possible, and get them on their way. So we're open 7 days a week. We can do micro intakes. We have standing orders. We can do the assessments. We can get everything in line, and possibly to have somebody turned around in less than 3 hours to have their replacement therapies, if it's uncomplicated. Here on this slide, there's a QR code off to the side. You can do your own intake via phone if you want to, and your information is protected. So we want to make this accessible to people as well too. And so far it's worked. We've had several intakes done through this. It still requires a clinical visit, so we can obtain blood and go through all the details and process and signatures and release of information signed. But for the most part, if you're struggling at home, or if you don't want to make the first move, or you're embarrassed to come to a clinic, or you just don't know where to start, our QR code intervention here is really good, and we've had some good results from it so far. So this is also exciting. I had talked earlier about doing outreach. In the corner there, you see the dry blood spot card. So dry blood spot is something that is new, and it's on a federal knowledge base in the laboratory, but it's not recognized in New Brunswick. But we do use this as a tool, and public health now will recognize it a little bit. Because whatever the result is on the card, if it does say HIV, if it does say Hep C, that's an actual result and we're forced to move on it. However, it's still a fairly new intervention in this province. And I think his name is Dr. Kim, who is going around educating people. I don't know if any of you out there have been on any talks about doing dry blood spot, but we have done it since the start. We're not Horizon, we're federal, so we get to do some different things that are not within Horizon. So one of these is the dry blood spot cards, and it only makes sense to do this on outreach. Walking around 10 site to 10 site with lancets in these cards and with identifier information to fill out and the proper storing and handling of them. This actually beats doing blood draws. So if I'm in a 10 site, and I've done this before with our peer support worker, there was one 10 site here in Fredericton where I set up a table and he went around to each tent and had people come see me. I got what they needed, either for intake for replacement programs. And at that point, I would take my lancet, I would draw blood. As you can see the cards, there's 5 spots there. The cards we test, or what we test for here, is obviously we screen for HCV or hepatitis C, we screen for HIV. We also screen for a viral load associated with Hep C. One can be obtained on the card. You can do an A1C and you can test for syphilis. So if you're traveling from 10 site to 10 site in a day and that's your shift, tubed blood is going to rot pretty quickly, especially in a hot summer day. So with the proper storage and handling of the cards, you can have them in your backpack and then go on to the next, come back to clinic, get everything organized and sent off to the lab for processing. So the only weird thing about it is that the viral load is not completely accurate. It's a range, so it'll say between 10,000 and a million, or 1,500 and 30,000. It won't give the actual quantitative value, but enough to know that there is an active infection in the blood and that it would need serology. Or if the card says target not detected or RNA not detected, then we just toss it and we do surveillance blood work after. So over to the side, the oral quick thing, that's usually to test an antibody. We rarely use that here. That's something mostly used in recap, just because we can send the blood overnight and the screen can be done pretty quickly. When you do an antibody test, a rapid antibody test, you could possibly build a little bit of stress around it, because say you've had Hep C and you've cleared it, but your antibody still tests positive, your antibody is going to test positive on this test. It's going to scare your patient thinking that they've been reinfected. So we sometimes limit the use of the oral quick, but definitely dry blood spot cards are definitely used by us. Others that work in maternity would probably see them for babies when you prick the heel. But this is the same principle. You need to fill the whole spot, but we're just testing different things, and just for practicality purposes, it makes it easier for outreach. Or in often cases, if we have somebody who is a very difficult poke or finding a vein for blood draws, we'll actually use this to do test to pure to see if RNA is detected or not detected after treatment. But serology, obviously, for a physician to sign off on the treatment, especially the ID docs, before giving the DAAs or the direct antiretrovirals. These are heavy medications. They cost a lot. Like I said, they want to make sure that the actual workup is in there, as well as basic serology. There's some other blood panels that we do as well before treatment. If everything is not complicated, we will go ahead with the treatment. But if there is some complications, especially in a liver profile, and different other lab readings, we will forward off to the infectious disease doctor or the hepatologist. That's very interesting that we can use both of those positions. They're very, very busy. Dr. Brandon Chase and Dr. Megan O'Brien. She is the hepatist and he is the ID doctor, but both have involvement with Hep C based upon one with overlooking liver, the other one with the infectious disease portion. So we try to limit what we put in front of them just because they're very, very busy. As you know, care is limited in this province in certain specialties. So if we can manage and do nursing-led treatment and keep patients away from them, it allows them more time to address issues amongst their care capacities. Moving forward. Trying to. There we go. So this is just kind of an idea of the pathway that we look at for results, whether it is from dry blood spot or if it is from quantitative value of tube blood. So if you look at the pathway there, you can kind of see what next steps are. So we have made it easy for our patients to obtain treatment. And when I say easy, it means that we have shortened the wait from 20 years down to probably about 6 months. 6 to 8 months, depending on where they are as far as their wait time between viral loads, and to make sure that they're not spontaneously clearing on their own. It wouldn't make sense to give a patient the $50,000 treatment if they're clearing it on their own. So all of these interjection or encounters, I should say, with nursing help facilitate this treatment going forward. So what's next as far as our treatment goes, when they come for intake, we draw their blood. If it is Hep C positive, we have to wait 6 months. And I put, yeah, really on there. That's actually a part of this province's workup for Hep C treatment. Technically, what we're looking for in this period of 6 months is if we do a quantitative value of a viral load, we have to wait 6 months and then redraw it. If the viral load has increased, that means that they are not spontaneously clearing. If the viral load decreases, then we need to wait and do more serology to make sure that they're spontaneously clearing and provide different blood value interventions along the way to make sure that it is decreasing, and then ultimately test at the end when it's completely gone. This happens to about 20% of people, and different genotypes respond differently. It's not a lesson in virology, but it's very interesting to me. So there's different ways that Hep C can move amongst the body, and with our patients, because they could have different genotypes, they could have different types. So they could have spontaneously cleared maybe 20 years ago, they could have been reinfected. So those could be two genotypes. We don't know what they are. So that's why with us, we need to really hone in on our nursing assessments, our interventions, and our encounters along the way before treatment is given. Because this is really big for an ID doctor or an infectious disease doctor to hand this off, not only to nursing, but to open the scope of LPNs to read and do the results and also process the care. So public health and reporting and contract tracing, we do that with patients if they need to, or we help public health. That's also new for us. Public health is primarily, I think, run by RNs, and for us as LPNs here to report off to RNs, it's a great scope opening. We review risk factors for transmission and a lot of education in here, the adult physical exam. I've just been graced to do all of the assessments now here for that. So liver hooking, a spleen assessment, as well as fibroscan, as you can see at the bottom. Fibroscan is like diagnostic imaging. It's kind of like ultrasound. I got my certificate in that last year. It's a very not invasive, procedure to have a look to see the structure and function, if the liver is fatty, if it's healthy, if it's not healthy. It's a very, very cool intervention to do. It actually is safer and much more beneficial than doing a biopsy. Getting one of our patients to go to a biopsy appointment is basically surgery. That's going to be not going to happen. Our patients stay away from the hospital as much as they can. So if we can do a procedure that's better than a biopsy, by all means, why not, right? But the only issue with the fibroscan machine is very, very expensive. We do not have one in the province. One is sent to us anytime that we need it. It's usually twice a year. It's sent from Ontario. So when we have it, we have to book out about 50 patients each day. I think we have about 3 days. So we try to correlate with the Frederick Downtown Community Health Clinic and do like a liver health day, but also have our patients treated in the meantime with that as well. Obviously, more serology is done on the lead up to it, and we also give our patients treatment options. So the medications that we use are DAAs, or direct antiretrovirals. So those medications are direct to a specific illness. But what makes it beautiful is that the two meds that we typically use are Epclusa and Mavorite. These medications are pan-genotypic, meaning that it doesn't matter what genotype, when they obtained HCV, both medications, Mavorite and Epclusa, are pan-genotypic, will cure Hep C. So there's 95% accuracy and clearance. Sometimes there are failures in treatment, but then it might be just another treatment option. But for the majority of the medication that we use to treat Hep C would be Epclusa and Mavorite. Epclusa is probably the primary one that we use because it doesn't require having food with it, and it's only one pill a day, whereas Mavorite is several pills, and you need to require food or else it's going to upset your stomach lining. So with our patient population who might only eat once a day, might eat every other day, who might not have hardly any intake at all, it doesn't make sense to make them more upset because they'll stop taking the medications, therefore you'll have a faulty treatment plan. So there's all kinds of different avenues and aspects involved in this care. It's one that's a passion to my heart, and we're now seeing positive results. We've been here in operation for 2 years, so now we're doing surveillance blood works now on treatments that have worked. So it's a very good, exciting intervention for this community. So at Riverstone Recovery, this slide again, this is a little bit old. We have more than 241 participants. This is an old slide, just because we have intake daily. We have some patients that drop off, some patients that come in. So this is just kind of give you the general figures. And this was, I think, at the end of 2019 or 2020, I think, going into 2021. So we do oral replacements, obviously IO. Now we have about 54 in IO, I believe I've seen the number today. Sublocade, we have about 15. Now, Sublocade is a very interesting substance to use. It is a sustained release Suboxone. So those patients that are on Suboxone, the sublingual tab, this is actually a medication that is that goes in under the skin as a bubble, and it slowly dissolves throughout the month. It works for 30 days, but we re-inject them on the 28th day. So this is a very good safety component, because if you're traveling, if you'd like to travel, what we've noticed is that there's actually 2 groups of people who really benefited from this. I know across the country, if you look at other stats, there's different ones, but I know for us, men, I shouldn't say men, but those who work in Fort McMurray in trades, there's a lot of drug use out west. So if they're on a replacement program and say you're in the oil fields and you have to go to a work site and it takes 3 hours to get there, 3 hours to come home, you could be there for 12-hour shift, and you're having oral replacement of methadone, you can't take that with you. Or if you don't want your employer to know, or you don't want anybody else to know, Sublocade is actually the best medication for it, because it lasts a month. If we inject you with this, the bubble stays in your abdomen. It dissolves slowly throughout the year. You can go, or throughout the month. You can go to your work. Nobody needs to know. Also, those that might have mobility issues in the wintertime, getting to pharmacy might be a big problem, especially if you're aged, if you're in a wheelchair, if you have assistive devices. The icy sidewalks are not helpful in this city. So if we can inject you with Suboxone or Sublocade, and you don't have to come out to pharmacy, then that's another safety parameter. Also, this summer, we noticed that we had some patients. We try to encourage as much work as possible. Different patients that were out on construction sites, they say flagging on the road or roofing. Sometimes projects go past 5 p.m., 6 p.m. at night, and depending on the project of whatever's going on, you might miss pharmacy, might close. It's really upsetting if you miss methadone or your Suboxone. Then you might have behavioral issues at work with patients being in withdrawal. However, with Sublocade on board, it's not a worry. And we do have overlap, I guess that last line, between our stimulant replacement programs and our opiate replacement programs, keeping in mind those are 2 avenues of addiction. So we may have people using coke and meth when they couldn't find hydromorphone or hydromorphocontin or fentanyl on the street, so they'll just take a stimulant instead. And in that time of like whatever the dealer has, they'll take, you could develop 2 dependencies. So there is overlap between IO, OAT, and SRT as well. So the next slides, these are actual quotes from our patients. It's the one thing that helps. That is a huge thing, especially some of these patients, they're not new to this. They have failed other forms of treatments and other processes in that linear line of expectation by caregivers and physicians, other care capacities. but we're here to help in another option. So it's really, that's a very interesting one at the top. Literally saved my life. Makes you feel you're important, like you're not just a patient, but somebody they care about. Has given me stability. Keeping in mind that even when we stabilize a patient, they still could be injecting. They might inject for life, but again, it's the recovery that goes on around them in their day-to-day that happens outside of our walls. So these are outcomes, and again, the percentage and the stats numbers on this slide is a little bit old. Our recording and reporting periods are very vast and in between, just so that we stay in the works here. We have a lady, Christine, who is our record reporter. She's a very busy lady. She takes everything that we do and all the stats, and she compiles this all together to keep our money coming in. So she's the one that generates all of this information, but it's just kind of a good kind of barometer to see, because she sits down in front of her patients without nursing, without the physician, and as an aside, and communicates with them one-on-one to deliver their complete openness of how we operate. So 90% have reported one or more positive changes. 83 of those reporting still using drugs before iodine. There's one in there that was really report some improvements to mental health, improvements to physical health, 58% less conflict in their lives. I mean, any benefits there, the numbers do show. And just moving forward. Research at Riverstone Recovery. Next year, we are going to be doing, we're going to be one of the test sites for national trial for crystal meth and methamphetamine use disorders. It's a 5-year multi-use national trial. So this is going to be facilitated by a different team, but under the umbrella of Riverstone Recovery. There's a huge stimulant misuser in our society as well that we're noticing even as we do intake and we go along. We're primarily opiate replacement therapies. We are noticing a lot of extensive use in meth and coke and any other stimulants that would be abused. So one of the correlations between this, as I said in the back, a couple of slides, we use dextrogen as a replacement therapy. The reason why we use dextrogen is that it's covered by the formulary in social development, whereas there's actually a better medication out there that works even better for curbing meth use, and that's Vyvanse. And those of you who work in psych care understand what that medication is and have probably had reports of your patients doing really, really well on it. So for a stimulant disorder, Vyvanse, the way its arc works in pharmacology is that the half-life, it's such a smoother arc throughout their period of the day, whereas dextrogen might have spikes and you have to lead up to it. But with Vyvanse still in its first stages, or I think it's in its 10-year, and it hasn't had any subsidiary or any others made by it, or I can't even think of the word, the step down from it, or the knockoff, if you will. Social development can't cover Vyvanse, so that's why we use dextrogen. But Vyvanse is going to be used in this trial, and if there is success in it, hopefully we'll have social development change their formulary so that we can include that we can include Vyvanse in our regular stimulant recovery package. And OpiVenture is one of a target intervention for opiate use disorder based on personality. It's like a 3-year study. So we have some other clinicians who use our patients as test subjects, not without their consent. Obviously, they have informed consent. And a lot of the initiatives that we do here when patients participate in other avenues of care and other research, we give them gift cards, usually to either a food place, Victory Meat Market, who's beside us. They get gift cards to there, or gift cards to Tim Hortons. Primarily, we prefer to give gift cards because we know where they're going to go use them. We try sometimes not to give money unless it's piecework and they're stable. I mean, obviously, you're going to get paid for work done, but we would like to promote health as much as possible. So gift cards to places that we have food or coffee, Tim Hortons, and whatever. A lot of our patients drink Tim's, and so we try to accommodate them and appreciate them every time that they participate in different surveys or questionnaires or other testing. Myth busting. So harm reduction enables drug use and entrenches addictive behavior. Not true. Harm reduction, as we've talked about, and as you probably have seen and know, the stats are there, the evidence is there that it does work, it does help, and it does assist a lot of people in their addiction pathway, and also their pathway back to recovery and whatever that is. Harm reduction drains resources from treatment and services. This is not true. And without reading the other side there, I just want to point out just a couple of things, just a quick example of how harm reduction works, primarily what we have discovered here for New Brunswick and in this city. Some of our patients before we were here had admitted to us using, so obviously if you have a substance to break down to inject, whether it's you're injecting cocaine, whether you're injecting amphetamines, whether you're injecting hydromorphone, crushed pills, however you were doing it, the medium or the substance used was water. Of course, you need a fluid with limitations to bathrooms, barriers to public places, not being able to purchase sterile water. Some patients would collect water from dripping air conditioners. We've had reports of patients using puddle water or even river water to cook down their substances before injecting. So obviously this posed a high risk of infection, and usually sometimes endocarditis happens. It's infection of the heart, also bad abscesses that can go sepsis if left untreated, all kinds of different health problems. But one of the things that we want to point out, and also osteomyelitis. So osteomyelitis as well as endocarditis in an ICU is going to take up maybe three months or longer to cure. You're also paying for an ICU bed, all the treatments involved, the equipment, you're paying for ICU nurses' wages, also the doctor. All of that money comes from somewhere and the patient isn't paying for it. So if we can keep a patient out of ICU without having the risk of infecting themselves with re-injecting puddle water or air conditioning water safely, we have assisted keeping them out of the healthcare system, thus saving money. Also, another avenue of saving money and resources for our province is that well, I shouldn't say all, but a majority of our patients have been incarcerated or have troubles with the law or are coming through or recovering their bits to correct legal stances. So along that pathway, if we are not, if we're not helpful in these patients, it's not going to benefit them. But if we are helpful in bringing them off street drugs, that way they do not carry them on them anymore. If they get caught, they won't have any substance to go to jail with or to be charged for. Therefore, we're keeping them out of the law system, because if they're incarcerated or if they need legal aid, they obviously can't afford to afford a lawyer. One is appointed. Any appointed lawyer that is working for the province is still getting paid by the province, even if the patient isn't paying for it. So that money comes from somewhere, and lawyers, as we all know, are not cheap. ICU nurses aren't cheap either. So if you're paying the wages of two of those people for something that could be brought out of harm that we could deal with here, that's ultimately a savings across the board. And I want to throw this out there as well. We also have law students come to our clinic, and we have what we call a law day clinic, where we sit the patients in front of these future lawyers and tell them, this is my experience, this is what I've experienced in the law. Please, again, it goes back to that nothing about us without us. So patients advocate for themselves of what lawyers should hear when defending them, and what to know when and what to do in future. So this is a really good benefit to save money in both healthcare and legal systems. We're also trying to figure out a way to have access to UNB's archives, either through law students, to figure out the cost of a patient on our system before IOT and how much they've cost the system a year after IOT. So we want to have that cost comparison there. That's a report that we're trying to get into the works, and it might be in a presentation a couple of years down the road. Again, like I said, our information sometimes comes a little late, but that's what's in the works, just to see for public viewing of how we are saving money here. And some people look at us as a drain of resources, but and it's proven that we are not. Harm reduction causes social disorders, threatens public safety and health. Well, if we're turning Hep C around, that's a public safety thing. If our patients are discarding their injectables in here, that's obviously contributing to safe street. And if we're giving out safe supply, then we're reducing the amount of infections and hospital stays. All right, I probably have gone way over the time, which I always do. But I would like to open it up for questions, and I've told this to Kathy too. I know there's a lot of stuff that I went over, and probably it could be a whole semester of coursework on everything that I've gone over. But I like to read, like I would like to leave my email out and open. We've done this before in other meetings where we've just let everybody just email questions in, and we've created a document to mass spread back out. So if we don't get to your questions right away, I would love to answer any one of your questions. It just give us some time to get out to that. So Kathy, I'll hand it back to you.
Perfect. Thank you, Brett. That was a really amazing presentation. I've learned a lot just in this last hour and a half, and really great work coming out of Riverstone. Absolutely. So if you're not sticking around for the Q&A, you can certainly just leave the meeting. If you do have questions, you can just type them in the Q&A box and we'll answer them here for the next few minutes. You always have the option to send in your questions anonymously. So if you don't want your name shown, you can just tick the little box there that says send anonymously, and we won't know who's sending it. So if you're not sticking around, thanks very much for joining us today. And I'm just going to stop the recording and I'll have a look at the questions and answer, or the questions, sorry, and Brett will answer them.